Hello and welcome to today's AHAM webinar 2023 CRIP webinar. I'd like to introduce your speaker for today, Caroline Zadanek, Managing Director with Protiviti. Caroline, if you're ready, the floor is all yours.
All right, thank you so much. So welcome everyone. Thank you for joining us today to learn more about the CRIP certification. This certification was created in 2014. I actually obtained my certification last year, and so I'm a new CRIP to the AHAM organization. And definitely this is intended for those that are in our revenue cycle more to understand, some of the revenue integrity type functions and some of the items that we come across in areas that we're looking for opportunity to improve the identification, capture, and ultimate billing of different services that are provided to the patient. And being able to receive the designation of the CRIP, we're really looking for those that have that in-depth working knowledge of various revenue cycle areas and that can demonstrate the skill sets that are necessary to identify those particular areas across the revenue cycle to improve revenue and reimbursement, and always behind the scenes the compliance component of that as well. So when we look at how the CRIP certification exam is pulled together, there's 4 different sections. There's charge capture, which will focus a lot on CDM type maintenance, getting into more detailed items related to the last 3 ancillary services, surgical, as well as some of recurring and clinical type services. So as we go through the presentation today, we'll be following along that same pieces too in those different sections. As far as the exam format itself, there's 250 questions. You have 4 hours to complete. There's also some true and false as far as how you answer those questions, and also including multiple choice. To requirements for obtaining your CRIP certification, looking across those 250 questions, passing at least 70% of those within each section. The number of questions do vary by the exam section. There's not the same amount in each section. If you do pass at least 2 of those, you can schedule to retake any remaining ones within the 12 months of the initial exam month. And then any retakes for the entire exam, if you only pass 1 section, you'll have to go through the entire exam again. To maintain your CRIP certification, must remain a member of AHAM and in good standing, as well as their continuing education requirements going forward for 30 hours, 15 of those to be earned through AHAM related type programs. If you're thinking of other organizations like AHIMA or HFMA or others, those may also qualify. So within each section of the exam, there are different objectives and topics under each section will be provided. Special attention to look for as you're looking through the CRIP manual and the different overviews is look for some different warnings, some tips and pins notes, information boxes, bolded words, some different knowledge checks as well. If you haven't already obtained your CRIP study manual or training guide, definitely, I will tell you, having taken it last year, that was very helpful to be able to reference back to that, to give you a real feel for not only a lot of what we're going to go over today, which is really a high level overview, but some of more of the specifics. But it's also good too to have that basic background. You can take that back to your facilities and your practices as well. I will note for the group that we are in the process of looking at updating the manual as well going into 2024. So let's start that first section that really, again, concentrates on charge capture. So a large piece of that comes down to the charge description master. And what that is really our menu of services that can be provided that can include items such as supplies, pharmaceuticals, services, like radiology, respiratory procedures, as we're getting into more surgical, like cardiac cath, different type of surgical procedures as well. When you look across the charge description master from the basics, when you think about the different components that are provided, and I know many of you have very complex EHRs, and so you'll hear a lot of times what has come about in the last few years with those more complex EHRs is a dynamic CDM. But the basics of what really we concentrate on and understanding was, as we say, the components of the charge master can be broken down even to a little bit more of some basic data elements. So the first being the item description. What is the description that's going to drive the different other elements that we have? And a lot of times that description is more technical. Sometimes it can be very clinical, depending on how many characters you may have in your CDM description. Also, you may see variances between a billing description versus a clinical description, as somebody may have something that looks different from a clinical aspect as they're choosing items to charge versus what we may see in more of like the back office type piece. But that item description really is kind of your more source of truth to understand then what goes into the next element as far as our CPT or HCPCS code. So what relates back to that description to describe what was actually provided or performed. Also, there's a revenue code. Revenue code is going to be more 3 digits, sometimes 4. People put 0 in front of it, which really describes more at a categorical level what the item or type of service you're providing. So, for example, in the 2.7, I'll say X because there's a range of 0 through to 9 in a lot of those ranges. In that 2.7X piece, that's supply. So within there, you have 2.7.2 as a sterile supply, 2.7.5 as a pacemaker, 2.7.8 as an implant. So it takes less of the detail from the HCPCS and item description, and again, more kind of rounds them together. So understanding what some of those revenue codes are and that relationship to how it relates to the HCPCS code, because there would be a relationship there. So if I use the pacemaker, for example, of a revenue code 275, I would likely see a C code that gives a little bit more detail to the type of pacemaker that is there. And then even going backwards into the item description, it may provide a model number or a vendor or some other type of qualifier or attribute. Another component of the chart multiplier. So this happens a lot in pharmacy as it's coming across the charge description master, is really looking at if I have a HCPCS code that describes a pharmaceutical by 10 milligrams, but I'm dosing and packaging that at 100 milligrams, I have a multiplier of 10. Additionally, other things that could show a change or a variance, a type of scenario related to that item, service, or procedure is a modifier, and that's a 2-digit. It could also be alpha, related to explaining, again, a scenario. Why is this different? So we look at anatomical modifiers, so left, right, there's fingers, toes. We could look at if it's a bilateral procedure with a modifier 50. Also embedded into the CDM. Less likely we would see hard-coded a modifier 59 that is describing a distinct procedural item there, because that's just largely frowned upon from CMS's perspective, because it should be more scenario-based and reviewed independently. So if you do see a modifier 59 hard-coded in the CDM, maybe an area to take a look at, but that's not one we would typically expect to see. And then another component of that charge description master is also our gross charge. If that is predetermined charge amount related to that item or service, that may also be in place. So those are the basic components of the charge description master. Again, as you get into more dynamic CDMs and looking largely across, how that has built out over the years, you may see some rules related in there against the billing categories, different rules-based items, might even see different charges and routers and logic built in, but truly we're focusing for this piece of it more on those basic components that I went over. The other piece related to charge description master is revisions or overall maintenance related to the file itself. So understanding those individuals that could be included in the charge master team. It goes beyond just the person that's at the computer driving the changes, but getting input from various stakeholders, whether it be HIM and coding, your billing department, and definitely your clinical adversaries as well, to understand what types of services and items that they're providing or rendering within their certain areas, to make sure that they are included, for one, in the charge description master. But as we know, on at least a quarterly basis, or I say at least on an annual basis, often on a quarterly basis, there could be changes that come about. It's more common on the annual frequency because we have annual CPT code changes that come out, as well as not only CPT and HCPCS changes, both on the annual and a quarterly basis, but we also could have revisions in intent or even rules around charge capture documentation that as the CDM is built, we want to make sure that that's reflected as well. Documentation of services. I think many of you have likely heard if it wasn't documented, it wasn't done. So really understanding a lot around charge capture is not strictly, checking a box that I provided a particular item or service, but I also have the documentation to support not only that it was done, but detail related to meeting that item description, the CPT definition or HCPCS component to really be able to defend should there be questions related to if the services were provided and if the right codes were in place as far as the charge capture and billing component, that piece is there. So documentation basics, obviously identifying the patient, the date of service, the mode in which this item or service was provided. So for example, was it a telehealth? Was this surgical? If it gets in surgical, what if there were any type of instruments and supplies, implants? We want to make sure that when we send a claim, and how I always look at it is if I were to be a computer and I look at the claim and I had to create a narrative story of how the patient came in, what was provided, do I have the right information there that's supported by documentation from the claim? If it's telling me this is what happened, whether it's a patient came in through the emergency room, it was related to an accident, it was on this date, this is why from the diagnoses we provided these types of services, all of that combined, I should be able to take that claim story and relate it back to the documentation of the services as well. So when we look at the claim form, the UB04 for our facility claims, there's a lot on there. If you guys have never really looked and taking, even just go on Google, look at a UB04 claim form and its beautiful manual view and really get to understand and appreciate all of the different value points and data elements that go into that form. Because what we see, what we don't see actually, is what happens electronically. I've been doing this for 27 years, so I've become very intimately involved with UB04 over the years of having to understand those different fields, and we kind of lose that having not seen that. So I would encourage you, just for interest, just to go in and just look at all the different data points. Some of those we'll talk about here as we go on, but it's a very complex form, and so you can understand as we're looking at opportunities for improvement. We're hearing a lot about payer denials, delays in payments. A lot of times it could just be simply one of those data elements was missing or incorrect, or it's creating a variance between potentially another element. So some of these elements I wanted to talk through. So when we think about the condition codes, it's really looking at, it's applicable to like the billing period. It could be situational. It could indicate, and it's a 2-digit piece that even, for example, charges are not covered. So it's giving a special condition to the claim that there's something here that's a little bit different. When we think about occurrence codes, this is most commonly onset of symptoms. So it indicates that here's the codes, here's the code for the occurrence of a sign and symptom, giving a date to another qualifier, and it can also explain specific events that are related. Value codes are more related to monetary conditions. So also being able to indicate that there's certain criteria to be able to qualify the claim. Examples we may see here are hemoglobin levels that are required for certain billings. And then as we talk about the revenue codes, that's a huge piece of the UB04 claim. You look in the larger boxes where we explain the services and items that were provided. It starts with, in the far left, in the middle of that claim form itself, is the larger piece of the revenue code. And then the revenue code drives more of the category, and then you can break it down by CPT, HCPCS code. So some of the same elements that we're talking about from the components of the CDM is what's driving what actually goes on that UB04 claim form. So making sure that those are most accurate and complete is really the main driver for a lot of the reimbursement decisions and really what drives revenue at the end of the day. So let's say, for example, you had the wrong revenue code associated with the HCPCS codes, and there's different crosswalks that are out there that could come back and question. It may not necessarily be Medicare, for example, it could be another payer. They may question, for example, even, and some of you may grin at this, like a 278 without a HCPCS code, or they're expecting certain HCPCS codes to have certain revenue codes, and they're not seeing that. So it flags as a mismatch. It's an easy way to delay a claim if you think about it from the payer side. So again, looking back at that CDM piece, make sure that's clean as it follows through that particular workflow. On charge capture, there is a section there also in the manual, and it talks through the RVRVS, say that 3 times fast. The resource-based relative value scale component, this is largely on the provider professional side. And this is more a physician payment system. So looking at some major elements related to ultimately combining different values to be able to come up with a payment amount with some adjustments. For geography, you have the relative value unit, the volume performance standards, as well as limiting charges. So there's algorithms and values in place, and just more of understanding for the purposes of the exam, what those elements are and the methodology that really creates that payment. The RVU, I think many of you have likely have heard of RVUs within an RVU value itself. So it's really looking to create a factor that is then multiplied by another factor that is provided by Medicare to ultimately get to payment. You can also use it for productivity. And what goes in there is work required. So they're assigning a numerical value to the complexity of what a service or procedure may represent. So what is the work required, as well as related practice expense and potentially also liability type expenses as well, to really be able to say, for the most part, what's more complex over another procedure, what's more involved and valued higher. So that's really where that relative value unit comes into play. The next section gets us into ancillary services. So if we talk about laboratory, we have clinical laboratory, pathology laboratory. You may also, for many of your facilities, also utilize reference laboratories as well. For the majority, a lot of these services are going to be included, hard-coded in your charge description master. So really making sure that you align the right CPT codes to the right descriptions, and understanding also that there are specific revenue codes by type of lab. So pathology has their own range versus clinical lab. So that's something to consider. And then also when we talk about some of the nuances of what happens in lab, and this goes back to charge capture as well as billing, is that date of service policy. So in general, the date of service for laboratory services should be the date of specimen collection. There are some exceptions to that, where a physician may order a test 14 days following a discharge from a hospital, and then other exceptions that have come into place through rulemaking, and this is largely driven by Medicare with other payers following suit, is the exception for advanced diagnostic laboratory test as well as molecular pathology test. And where that data service differs is by when it was performed versus when the specimen was collected. So that's just more not expecting you to know what CPT codes are molecular versus advanced diagnostic, but more in general of understanding molecular pathology can be billed by the date performed versus, let's say, a basic metabolic test, which would be by specimen collection. We talk about radiology and those considerations, grouping in like fluoroscopy, you had MRI, you could also throw CT kind of in there with MRI, PET as well, together with nuclear medicine. Some of the items to keep in mind on the billing implications, if you think about fluoroscopy, that's one that typically is not a standalone charge. And a lot of, even though it can be in your charge master separately, there are certain procedures that include fluoroscopy, if you think from a surgical standpoint, within the procedure description itself. So if you look at the CPT code, by definition, it says including imaging guidance, and you may see that in some and not in others. It's really understanding going through that if it includes imaging guidance, that we don't bundle that in, that fluoroscopy charge. And that can happen a lot of times where we see where it gets bundled or unbundled is when fluoroscopy comes to provide assistance in the OR. So keeping in mind, again, general concept that could be a potential for unbundling, and just realizing that fluoroscopy is a high risk there for that particular scenario. MR studies as well as CT studies, there is in some of those codes a difference between having contrast, without contrast, understanding with the anatomical components as well of where that particular codes should be selected and how that should be selected. When we get into PET and nuclear medicine, it's also understanding the requirements around more so medical necessity, especially for PET and nuclear medicine. These are expensive tests, so we want to make sure that we're meeting coverage guidelines in that way. And also, it's not just about the test itself. You may also have a radiopharmaceutical that is captured together with that particular item. So from a charge capture perspective, making sure that you're capturing both the service and the pharmaceutical together as well. Also on the PET scans, just something else to consider is there are limitations, at least from a Medicare standpoint. And again, I know we focus a lot on Medicare, but other payers like to follow suit on Medicare's rules as well, so they don't have to create their own necessarily. There can be benefit limitations related to the number of PET scans per year, which is 3 for the most part, unless you get an exception to that. But in general, it's 3 per year. When we talk about screening versus exams, this could be limited to coverage and limitation frequency. So get to in your guide, as well as grab a general understanding around the screening requirements, the frequency and which items can be charged, and the differentiation between a screening and an exam, or you might even say a diagnostic type exam. So I think one that's easy to really pick on, if you think about the breast screenings and the mammograms, is 1 every 12 months from a screening standpoint. But if you're found to have medical necessity and need diagnostic exams, that can be at a greater frequency if you have demonstrated medical necessity. So it's really back to truly the definitions of screening. Are we looking for and have we identified an issue to then turn it to an exam by definition? Right, we're going to keep going. So the next is vaccines. So when you think about the billing rules, and we'll look at the Medicare vaccines themselves. So when you capture a vaccine charge, you have the product itself and you have the administration. The difference with Medicare is they have their own HCPCS codes. So if we think about HCPCS versus CPT, CPT for the most part is numeric, and the HCPCS codes can be alphanumeric. So a HCPCS of a G code for the administration, and then you have the product itself, where if we have a Blues or an Aetna or another payer, they're not going to accept those G codes. They're going to want the 90,000 series administration code. So the basic here for the billing rules is understanding that it's not just the vaccine itself, that we make sure that we capture the administration and we have the right revenue code also associated with the vaccine administration, which I believe, and I'm pulling this off memory, I believe it's 771, to be able to make sure you have those both components, because that could be a charge capture opportunity, as well as you may have some payers kick back and say that it could be a question, if not a denial or reduced in payment, it could just be a question to come back in an audit of billing for vaccines without administration. The vaccines under Medicare that are impacted by the G codes are influenza, pneumonia, and Hep B. So there's 3 different G codes for those administrations, as well as they require a Z as in my last name, Zananek, code for diagnosis. So you make sure that you have coverage for that. So that's another component to be aware of. Drug administration, always a hot topic when we think about infusion therapy and injections. So documentation is largely around start and stop times in providing the particular services, especially when we get into infusion. So it's making sure that we have the time and duration as well as the route of the administration that is documented. So those routes can be infusion, obviously injections, and IV push or push injections. Also want to be able to document as well initial, sequential, and concurrent, and that would be in the clinical documentation. And then, as many of you may be aware, there's a hierarchy as far as CPT code reporting, chemotherapy having the highest therapeutic and hydration. So if you have both chemotherapy being provided the same day as a therapeutic type injection, the initial CPT code for the services is going to be chemotherapy, and then you can have your sequential into the other care categories. So make sure that you're comfortable with understanding the hierarchy and which one would come first in certain scenarios. And then as far as abbreviations in drug administration, you're going to see INJ for injections, IV for infusions. You can see IV, PV for piggyback or push, or IVP for push. And that really helps just if you were to go back and review the documentation and being able to translate that documentation to, again, that route and how that medication was provided, to be able to recognize that to get you to the right CPT code. Pharmacy. Pharmacy is very complex. I'm actually in the process now of doing a pharmacy review, and I can tell you it is very complex. Pharmaceuticals are identified. You think about when you go shopping and when you go to check out, the cashier scans the SKU number and identifies that particular item, where the manufacturer was. It could even have the size, very similar to NDCs. So it's a national drug classification, typically an 11-digit code, and it breaks down who the manufacturer is, the package size, the type of drugs. All of this ties into the pharmaceutical formulary or extract file that you pull together that really explains what the drug is. It gets into route, the dispensing form, and then also some of these other items too. So understanding there's a relationship many times to being able to translate NDCs to HCPCS. HCPCS will also describe from CMS's perspective, for example, for Medicare, it's going to give the generic drug name as well as the lowest unit of measure they typically see by package. So if something is typically packaged in 100 milligrams, that's likely going to be the HCPCS amount to calculate against, or it could be something that maybe is ordered at 100 milligrams, but typically could be provided by 5,000 milligrams, typically, how you have it set up in your pharmacy system. And that's where we get into that multiplier component as well. So when we look at pharmacy, it's looking at how that item is coming across and dispensed to the patient. And a lot of times that is calculated within the pharmacy system, but making sure that we're collecting the HCPCS units along the way. So again, if the HCPCS describing 10 milligrams, but we're dispensing at 100, that we have a multiplier of 10 to make sure that as that's coming through, if you were to read the claim, like a story, create that claim story, it's going to say, I saw drug A, 10 milligrams times 10, they gave 100. Want to make sure that that lines up correctly. If you have something that is actually wasted, so there are rules around drug waste. And a lot of times you'll hear folks talk about JW, JZ modifiers newer, but really being able to calculate and be able to get credit for that drug waste. And so this is specific to single-use vials where you may have some amount that is left over. So an example of a single use, let's say the vial is coming in at 100 milligrams. but we only provided 50 of those, and the HCPCS codes is per 10. We want to be able to demonstrate by 2 different lines what was actually administered, and then a separate line on what was wasted, and that's where we apply the JW modifier. New rule for this year is on the reverse, so you would assume that if you didn't have the JW modifier, there was no wastage. That was in prior years. Current year moving forward is now adding the JZ modifier to that top line to say we know that we didn't waste anything. So it's more of an attestational type modifier currently and going forward. Self-administered drugs. Medicare's policy on self-administered drugs is they're excluded from coverage. Hospitals do have a choice to make on whether or not, and they have to apply this rule across the board, is if they want to make those patients chargeable or not. The rule there is if you decide that you're going to charge Medicare patients for those self-administered drugs, you need to charge everybody for those same amounts. So there's some hospitals that do, there are some hospitals that don't. They'll take that into their cost. There's others that actually will bill that to the patients and try to collect on that amount. When we get into EPOGEN, so this is for a lot of times those that are on dialysis or have other needs. There could be ESRD and non-ESRD implications. There's specifics there around coverage related to that piece. And so Medicare wants to understand if it's ESRD or non-ESRD related. So just knowing that that is a requirement in the Medicare rule, and there are particular modifiers that indicate, yes, it's ESRD related versus not. For example, like there's an EA, so these are modifiers that start with an E. And then if it's ESRD based, there's also going to be a requirement to provide information related to what they call the URR, which is the urea reduction rate. So being able to collect that information as well. So there should be a process within your charge capture methodologies and documentation to be able to pull that value in and into the claim as well to be able to support the charges. Otherwise, you're going to hit that last little check mark there, and you may see a denial come back and request for that additional information. Transplants, and this is an area that many of us probably on the call have not necessarily had experience with because maybe your facility does not provide transplant type services. So in this section, and I will tell you there are questions in the exam related to understanding kind of the basics around transplants. So understanding what transplants are covered. Again, you can look at the Medicare National Coverage Decision to get some information there. There's also obviously in the CRIP manual, we'll give you information too. So looking at the organ transplants here, we have kidney, heart, liver. There's also stem cell. And then looking at your basic standard charges, you're going to see inpatient charges. You're going to see registry fees, acquisition charges for actually getting the organ itself. If you have a donor, if there's surgical complications related to that donor, that may also be covered from Medicare standpoint. Blood components as well, and immunosuppressive drugs. So understanding those basic charge elements will be beneficial to you for the exam. And then also understanding the types of donors, whether it's a donor coming from outside, if it's coming from a donor bank, if it's coming from someone that you've identified, if it's coming even, they're taking components from yourself as well as it's getting into more of the stem cell type transplants. Bariatric surgery. So we talk about documentation and coverage around bariatric surgery. Again, focusing on the Medicare CMS requirements. There are requirements as far as qualifying for bariatric surgery. So they're looking for documentation to be able to support that the patient has been obese for greater than 5 years, and that's being defined as a BMI greater than 35. And that also there's a condition related to the patient being obese, so it's creating other concerns and problems. Maybe that could be diabetic in nature, or is providing for other issues that, should they be able to lose weight, should be able to be controlled or be rid of. Also, that they failed at least one weight loss program, so they tried to lose weight and just were not successful. And then also needing a letter of medical necessity from their physician as well. Coverage for bariatric surgery is defined as either gastric bypass, or it could also be the laparoscopic banding procedures. And based on the type of procedure that you have will vary on your coverage as far as what is reimbursed. On the inpatient side, that's largely covered by Medicare. On the outpatient side, there's a cost sharing component there as well. But the coverage piece that we're more looking at is around that documentation and what qualifies someone to be able to get the surgery and the assistance themselves. Inpatient only procedures. These are identified, and where you would be able to identify inpatient only procedures. If you're familiar with the OPPS Addendum B as in boy, you will see all items and services listed for the most part there. You're going to see a column SI for status indicator. Look for status indicator C. That will give you a list of inpatient only procedures. And as you may Google or go on CMS's website to look for that Addendum B, you will see that those are at least updated annually. A lot of times they have corrections or quarterly updates as well. But for the most part, if you look at it from the annual files, you will see what is there on the status indicator C. So billing rules there, as I say, inpatient only. You will get flagged if you have an inpatient only procedure on an outpatient claim. There are some exceptions that may require appeal or different discussions should a patient had come in for an inpatient only procedure and perhaps maybe they passed away or there's an extenuating circumstance. Those are exceptions, but for the most part, you're going to receive a denial if you have an inpatient only procedure on an outpatient claim. It is worth noting that the inpatient only list is starting to be phased out. We've seen some back and forth over the years on some items going on, some coming off, but I think largely starting to look to pull back on the inpatient only list. And that's really coming from the provider community of not having a payer dictate how they provide services. Where the payers are coming back from is they want to make sure their beneficiaries are receiving care in the most safe environment that they can. So that's where the background of the inpatient only list came from. I would say, my opinion, my personal opinion is what's out there on the inpatient only list. As a potential patient myself, glad to see it. It scared the crap out of me, honestly, years ago when they took pacemakers off of that. If I ever need a pacemaker insert, I certainly want to stay the night just to be sure it's working. But that is one that came off the inpatient only list a few years back. So definitely with the advances in medicine, the provider community is pushing back to say more and more can be done on an outpatient basis. And that's why we're starting to phase that piece out. Interventional cardiovascular. So this can include cardiac catheterization, your interventional radiology type procedures. Biggest pieces here is to make sure too, you're not missing your implants. They are separate or captured separately. So being able to identify, what implants there, even high cost type supplies. If you have catheters or implants are going to be more stents, pacemakers, defibrillators, those different types of implants are definitely ones that we want to be able to include. When we talk about no cost devices, these are items that may have come back because they either need to be replaced because of time and the length it's been that the item has been implanted. Could also be recalled. So the manufacturer has a recall and is providing devices at no cost for that replacement. How that should come across is a condition code. So as we talked about this earlier, in the slides. There are condition codes that would indicate this item is replaced or recalled, as well as a value code that would provide the dollar amount that was reduced or credited. If your system can allow you a $0, that is preferred, but some systems do not allow $0 items to make it their way to the claim form. You can put in $1 to be able to get that line to the claim itself. We talk about surgery. We obviously have the surgical time that is involved, but also there's anesthesia that is largely captured by start and stop times. Also, conscious sedation is something to consider if that's being captured separately, or it could be included in the procedure itself, as well as recovery room. These are items that may also be part of your surgical components. So it's not just necessarily the surgery being performed itself, but also looking from a charge capture perspective, are we also expecting to see line items for these individual items? And there are different ways that we've seen, and I'm from Maryland. So for example, some of our Maryland hospitals may not charge for anesthesia separately because they have the cost rolled into their surgical components. Conscious sedation is largely driven by CPT code definitions, and if that can be captured separately. And then recovery room, that's one that there's not a national standard out there. You capture that by minute? Is it a flat rate? But just understanding, are these items able to be captured and charged separately, and understanding the methodologies around those. More so from a CRIP certification and exam piece is just identifying what those different components are. So if you were to think about like a multiple choice question, does an is E&M part of a surgery component, in comparison to these other three? No. Or is this item a surgical component, true or false? That's the level of detail that you would want to understand. So that next section, recurring outpatient, we think about recurring, repetitive, cycle type billing. So repetitive services required to be billed monthly or at the end of treatment and billed on the same claim as any other items or services that are utilized to furnish or support that particular repetitive monthly service. So examples of repetitive monthly we typically see are your therapies, so physical, occupational, speech, as well as cardiac, pulmonary rehab, and dialysis. Per visit are all of those other items. You can look at your MACs as well as CMS and looking at, as we talk about revenue codes, the different revenue codes that could push you to a recurring service and requirements there of what they may look for. And at the conclusion of treatment, let's say you concluded treatment at the middle of the month, you don't have to wait to the end of the month to submit the claim or put that in there. You can say, here's the conclusion of treatment, here's the end of treatment, and that goes forward into your claim itself. Outpatient rehabilitation. So if we think about, let's take physical therapy, for example, there's a process of certification and recertification. Certification at a minimum is 30 days. It can go up to 90 days, but there's caution there to not automatically always have a 90-day certification period. There's a potential there to be audited and have a red flag because it could show potential issues, again, relating back to patient care efficiencies and different not meeting medical necessity. So making sure you stay at least within that 90-day period for certification. So understanding the timing requirements is a piece here for the exam itself. And then the recertification is similar in time period. You want to get that recertification towards the end of the certification treatment. And then the plan of care is always understanding medical necessity related to why the patient needs the treatment, the different modalities that are going to be utilized, and the frequency, and then the overall expected time period of the certification itself, because that's largely going to drive how much time you have, and then also triggering into your recertification period too. So we think about provider of care modifiers. You have GO, GN, for example. So really being able to relate back, is this a physical therapy service? Is this an occupational service? and making sure that you have the right modifier attached based to the provider of care. So just knowing what those modifiers are will be helpful for you also in the exam, understanding certification, recertification periods, and the basic requirements of the plan of care. When we talk about recurring outpatient, so again, information needed for the rehab claim. So obviously the documentation we talked about, those occurrence codes, which provide span of care detail. It could also be information related to, signs and symptoms, onset of symptoms, your value codes we touched on, therapy modifiers. There's also Medicare Part B therapy cap reporting. So there's a particular dollar amount year by year. This year it's $2,230 for 2023. That's provided and allowable for Medicare. If it's exceeded for procedures to be covered, there needs to be an additional modifier KX assigned to those particular line items. So this becomes an exercise in identifying what services have been provided, and it's almost like an accounting exercise to see if someone has met their therapy cap or understanding where they may be in communication with the patient as well. So involving them and understanding their course of treatment and how that may hit them from a cost sharing perspective or the claims processing component as well. So just being aware that there is a therapy cap, what those caps typically mean, and the modifiers and exceptions to be able to indicate should you meet that cap. The 8-minute rules, we talk about billable units. There's many CPT codes, especially in the rehab space, that talks about each 15 minutes. It's not necessarily, if you were to think about calculating units, a 0 to 15 minute piece. It brings in the 8-minute rule. So to qualify, for example, for 1 unit, you have to be able to document that you provided that particular modality for 8 to 22 minutes. So there's always an 8-minute component to that. So the second would be 23 to 37, 38 to 52. It just goes in that method. So understanding, and for the exam itself, is understanding how to apply that 8-minute rule. So if I were to say, I'm going to bill for 1 unit of service, is that 8 to 22? Is that 0 to 15? What does that look like? That's the level that we're looking for there, is just to understand that the 8 minutes, how they come into play in those particular ranges. And there are some codes that aren't timed. These are mainly for the time codes, and where we see that a lot is in those recurring outpatient services. Okay, radiation oncology. There's different types radiation oncology I want to talk through. So brachytherapy. One thing to know about brachytherapy is it's very complex. There's different pieces and services that go into brachytherapy. So being able to understand particularly what those are. So if you think about special treatment procedures, that's really looking at the brachytherapy itself and that delivery of that piece. And it does kind of require some special arrangements with your OR, different folks, acquisition and preparation, different things of radiation sources. Also have simulation, dosimetry could be provided within that itself, isodose plans, all of which have their own CPT codes. And I also would tell you, just going back to your facilities and understanding a little bit more around radiation oncology and brachytherapy, there are some codes that are specifically provider driven and those that are more technical and facility driven as well. So understanding the different components of brachytherapy, and then within some of those different CPT codes that make up brachytherapy and the plan across providing that treatment, you may also come into CPT codes that are indicating simple, intermediate, complex. That gets down to, for example, in isodose plans, that could be defined on the different types of sources and ribbons that may be utilized that are going to define that, as well as into the treatment devices in a similar way of what's simple, what's complex, and intermediate. So that's an opportunity for you to go back, look at the CPT code definitions, get comfortable with those ranges within that piece, understanding that there is simple, intermediate, and complex, and all of the different components that could make up, if you were to think about a series of what would happen across the brachytherapy cycle, being able to identify those as well. Wound care, we talk about wound care. There's two types. There's active and surgical, and within active, there's selective versus non-selective, and there's different CPT codes there as well to describe those. Documentation for the most part in wound care is definitely size, depth, appearance, being able to demonstrate that in the documentation will be able to help determine what the type of wound, the mode in which it was treated, as well as a lot of our wound care CPTs, especially in the incisional and different areas, are based on size. So being able to understand that measurement and the different basic components of what goes into the documentation. So what's going to pass muster? Should you be audited? It's really, again, so it's size, it's depth, it's appearance, being able, and for the treatment itself, what different instruments were used, what was the methodology? Was there debridement involved? Was there skin grafts included? It's all of those different components need to be documented. One area we found in wound care as well, and this has been out there for a few years too, is being able to separately identify E&Ms. And this doesn't just sit in wound care, but we think about the appropriate use of modifier 25. For example, as far as having a distinct visit from the procedure, if I have a patient that I have scheduled to come in for a procedure, it doesn't automatically allow me to bill for an evaluation and management CPT code. We have to be able to show a separately identifiable. So in that instance, if I still scheduled a patient to come in for a particular wound care service, and while they were there, they had another issue that needed to be addressed, maybe they had another wound that had appeared that needed to be looked at again, assessed as well, that's what's going to drive us to get to an additional evaluation and management code. So that's more of a scenario-based type question. If you're thinking about it from a certification exam standpoint, is in this scenario, would I or would I not bill for a separately identifiable E&M? So if it's not related to the visit, you have documentation and the need for a separate assessment, management criteria, then yes, you can charge for a separate E&M. When it gets to hyperbaric oxygen, there's definitely rules. So by session is where we're looking to see hyperbaric. Some of the components around understanding hyperbaric is also that you could have an evaluation and management component to that. Again, it needs to be separately identifiable in that way. So make sure you take a look. There's an NCD out there as well for Medicare, as well as information provided in your study guide that will give you the basics of understanding oxygen treatment. Also specific diagnoses codes that provide coverage as well. Observation, always a hot topic. So looking at observation is first understanding, that observation is an outpatient status. So keep that in mind, as well as understanding that it is a status and it remains outpatient, that we must have orders to support observation. Documentation should be able to support the need for why the patient needs to be in observation. We're just not getting them out of the hallway of the ER and moving them to a separate unit, but that they definitely need to be observed and not necessarily meeting the criteria for inpatient status. It's also not a holding area because we can't have a particular diagnostic test done until Monday morning because that's when the staff comes back. That's not going to hold muster either. Calculation of time is starting the time based off of that order, but also being able to support within documentation that regular monitoring and checkpoints. We're just not putting a patient in observation and forgetting about them for hours and days that we put them on the floor. Talking about included services, and it's more of a conversation around carve-outs. If you have monitored type services, those are not included in the calculation of time for observation. So let's say if you had a service where you needed to take them to another floor, let's say they leave observation, they go to, let's say, CT scan. They still require, some level of monitoring. There's certain scenarios where you can carve out that time. That radiology test, for example, may come separately, and that time comes out of the observation. There's different components of that. You don't have to have actual time. It can be averaged. That's another component to understand as far as what's not included in observation. So if you are carving particular services out of your observation piece, make sure that that is known. So more understanding just the basics of observation, that the calculation of time isn't just start and stop, but there are carve outs, and that the carve outs don't actually have to be, again, exact minutes. You are allowed to do an average as well. Inpatient order changed to outpatient status. So this gets us into, you'll hear about condition 44, and understanding that this needs to occur before the patient is discharged. So a lot of times that involves utilization management and others. So again, it's more just understanding that general rule and what that condition code is and the process for being able to make sure that you bill that out appropriately. And then patients that are in surgery, orders for surgery should not include observation after surgery. It should be on a case-by-case basis and require a separate order. So we want to make sure that that is separated out and not included. So again, just more of it around the general rule. Evaluation and management, talking about more of the technical facility charging. There's two different types of EDs. There's a type A and type B, based on if you're open 24/7 versus you may close at midnight, open back up at 8 o'clock. Levels of care mimic and mirror the physician levels of care. So levels 1 being the lowest intensity to level 5 being the highest, and then also have critical care outside of that as well. Levels of care, there is no national standard on the technical side for determining if something is a level 1 through level 5. There are 11 guidelines that have been published by CMS, which gives you basically some guardrails for creating your own internal guidelines. So that's just a point to have there for the purposes of the exam, as well, is understanding that it's up to each facility to create their internal guidelines and how they come up with the different levels, but there is not a national standard. Multiple visits in the same day can be indicated on the claim with a modifier. Medical screening exams and the E&M charging. I've seen some hospitals separate out the medical screening exam and the actual visit charge separately. This is more of a payer or regulatory piece. If we look at some of our hospitals under all payer models, may have some different requirements where they have a separate line item for that medical screening exam versus the total level of what was actually performed. So you may see a level 1 for the medical screening exam with the medical screening exam revenue code with the ED visit with the actual visit level. So a 2 through, we could actually repeat a 1 too as well, but 2 through 5 with the separate revenue code saying here's the actual visit. On outpatient clinic visits, new versus established, the 3-year rule applies on the technical side as well. So I'll give you an example. I had a primary care provider I hadn't seen in 5 years. I had a hard time getting back in there because I was now considered a new patient. I had exceeded the 3-year time frame, but definitely, it still applies. So understanding that there is a time frame there on new versus established and based on the facility, not necessarily the provider in particular. So if you think about if I went to the emergency room 2 years ago, but now I'm a new patient to the wound care clinic, I'm an existing patient to that facility, not a new patient because now I'm new to that clinical department or that new provider. And then we talked about separately identifiable rationale whenever the 25 modifier component related to being able to separately identify a visit from a procedure. So again, being able to demonstrate that it wasn't something that is included with the service that's already scheduled, or if I'm coming in just for a new visit, and as I'm there for a particular reason, maybe I have a cough, for example, coming into a provider practice, but hey doc, while I'm here too, I also have these other issues, and maybe I have a wart or something, and he freezes that off or does something, gives me an injection, those are separately identifiable. So knowing when to apply the modifier 25 is the bigger component here. And then on the provider piece, we talk about evaluation and management. You have, your exam, your medical decision making, all of those different components of the evaluation and management side too. So making sure that we have documentation related to, the why are you here? What's the background? What decisions, what results do I need or testing that needs to be done? What is the decision made to treat you now, and what are we going to do in the future? So just making sure, again, you have that documentation to support the level of E&M that comes out at the end. So getting into other resources. So within the manual, you'll have a glossary, there's index. There's also other manuals from AHAM that also may be of help too in support of this. So we have the CRCE, the CRCP, CS and CCT. Always good manuals to have. And also, if you haven't already looked at those credentials, may also be something to complement your CRIP certification as well. So definitely worth taking a look at. And so here's just some of our tips, some of the differences and different pieces, just kind of to highlight what we were talking about earlier. So understanding, and this is really, kind of, pay attention, hint, hint, understand the differences. There may be a question related to this. So understanding differences between emergency room type A and type B, your different types of labs. I don't know if I touched too much on lab panels, but really the bigger thing there on lab panels is understanding that you may have a more comprehensive panel that includes multiple tests. So make sure that you're not including a larger test. It could be an organ panel type test that has all those individual testing, that you're not unbundling those on top of the panel test as well. And then as we talked about the lab policy for date of service, modifiers that are informational versus reimbursement. So if you think about informational, like an anatomic LT for left is a little bit more informational. It's not going to drive reimbursement, where a 25 modifier is going to separate out that E&M from that service and procedure, is going to be separately reimbursed, or applying a 50 modifier could affect reimbursement. A 52 for reduced could affect reimbursement. So really understanding what's more informational than what's going to drive revenue. Screening services and coverage. So this gets into frequency limitations, as we were talking about what's screening versus an exam. So we have the pap smear, cancer screenings, mammography we touched on as well. And then vaccines, there's Medicare specific coverage of vaccines. I talked about influenza, there's pneumonia, there's Hep B. So there's coverage on frequency related to those, which are typically on an annual basis. As well as some specific criteria for coverage and what you need as far as the right CPT codes. And we also talked about the diagnosis code as well. Understand differences between coverage determination. So you have, I mentioned a lot, NCD, so that's National Coverage Determination. When you get into more of the regions, you start talking about your MACs. There's the local coverage determinations as well. So coming off of the NCD, if there's an LCD, the LCD is going to trump the NCD. And typically what it is it'll mirror, for the most part, the NCD, but there may be some specifics. Maybe it's addition of certain ways that they want things to come across in documentation, or they have requirements related to medical necessity. There's additional diagnoses, anything that might be just a little bit more detailed than the NCD. And then definitive or non-definitive coverage determination. There's some that cannot be changed. There are some that can. So really understanding your LCD piece and knowing what is applying and different versus what is going back to more of that federal NCD type level. Status indicator, Medicare Addendum B is your friend all day long. To understand status indicators, payment, and driving, where certain things are paid. So being able to understand what that status indicator is and what it's used for. So it helps to indicate if something is excluded, if it's bundled into a more comprehensive procedure, if it's getting you to APC packages. We talked about status indicator C for inpatient services, and then understanding that impact. So as, for example, as we talked about the status indicator C for the inpatient only procedures, understanding that if we bill that on outpatient claim, we're going to be denied. Also understanding if we bill something with like an E1 or an E2 that's excluded from coverage, we're not going to receive reimbursement. So just understanding what those impacts are. Same thing with status indicator N as in Nancy. That's not going to have a line item reimbursement because it's considered bundled into the primary service of procedure. Understanding also the differences on our procedural coding system. So CPT codes, those are largely our numeric codes, start with a number. That's our level 1. We talk about HCPCS codes. Those are alphanumeric, most commonly used for sometimes new technology or new services. So C or G codes may include those. You could also see C codes for devices, talk about like pacemakers, stents, those types of items. Pharmacy starting with J. So you'll hear about J codes. Those are the larger ones on the HCPCS codes by range. And then revenue codes that require HCPCS. So I'll pick on pharmacy real quick. So revenue codes that require HCPCS, for example, in pharmacy, a 250 does not. That's more generic. A 636 does. And by definition, it says detailed revenue code for detailed HCPCS reporting. So understanding what the revenue code relationship is to required HCPCS, and just in general what some of those different bucketed revenue codes are. Procedures versus supplies. So as we're talking about, for example, the vaccine administration, we have the procedure of administering the vaccine, and then we also have the vaccine itself. It's not a supply, it's a pharmaceutical, but it's the same type of item. We have a pacemaker insert as the procedure. We expect to see a pacemaker implant as a supply. So just being able to identify when we separate those different pieces out, and we're capturing both components. So some of the strategies in general, just our general terms, be familiar with the UB04. As I said, it's always a good practice just to go out and get a copy of one and just kind of look at what the different fields are, get familiar with those particular areas. And we touched on value codes and condition codes to be able to see what some of those are in play, and maybe even look online, look at some of the LCDs, the NCDs that are even out there, and see some more of the common ones. We want you to understand the concepts more than memorization. This is not a coding test. This is not just I'm telling you this is what you need to remember, but just more conceptually understanding the basics of where we're coming from. Look at the glossary, get familiar with the terms, understand some of the modifiers. So you'll see those as well. Acronyms, I think this industry in healthcare has the most acronyms I've ever seen. Understanding what those are. Some examples there are medically unlikely edits, so MUE. Those are where your units of service exceed a standard that CMS has defined as it's very unlikely that you provided 2 pacemakers. I don't think somebody has 2 hearts, those types of items, or they only allow you to have a certain amount of venipunctures per day, but you had 20. They're going to edit out. Advanced beneficiary notice. So this is that notice form that allows the provider to let the patient know that the service may or may not likely be covered, and ask for their signature and understanding that they could be impacted by the cost sharing component. MSDRG. So this is going back to our specific, DRG groupers, different pieces. You also may see, so it's similar to like CPT HCPCS. This is the indicator for wrapping up on an inpatient basis what largely this patient was treated for. So it could be a joint implant or a respiratory type thing, or cardiovascular failure. That's that MSDRG code. And then for timing and practice, definitely, some tabs and flags, and in the manual, you'll see some different pieces that are highlighted. We talked about different areas. Just helping yourself too, going through the manual. You may just want to get a sense for how long it takes you to go through, tab that piece for you. I can tell you when I took it not to brag, but I didn't take the 4 hours. I was a little bit scared about the whole 4-hour piece because I was thinking that's a lot of time. But if you prepare well enough, it won't be so daunting. You can get through it pretty quickly. On national rules, we do have some physician concepts in here as well as facility inpatient and outpatient. There's a lot of focus, as I said, on Medicare and CMS policies. So we're not getting into the nuances of some of the commercial payers that are out there, looking more at the Medicare component. Definitely, again, if you haven't seen this repeated enough, modifiers are definitely in there as well. Understanding your reimbursement models, so APC, your prospective payment system, and some of the others. So really at a high level, it's like understanding where to get the status indicator because that's driven by PPS. That's going to be an addendum B. And then coding versus billing versus reimbursement. Just conceptually, again, understanding who's coming in from a CDM component and helping to identify what CPT and HCPCS go into the CDM. That could be HIM. Understanding their role as services may be captured in time-based units, and we need their assistance to, if like this happened in surgery, to abstract the actual code to be applied. How that goes across to billing. So if I think about it from an HIM standpoint, they're not necessarily going to be driving our condition codes or our value codes. That's something that comes more so into the billing world. And then reimbursement, understanding how that information comes back. What do we need to have to reduce denial? So just getting back to the basics of the right diagnosis code, our documentation's appropriate. We have the right modifiers, the right revenue codes. Just understanding across that continuum, the different pieces. So some of the strategies in test taking, it is a time test. Breathe a lot, take some breaks. Elimination method. So as you're going through, let's say, for example, it's a multiple choice question. If you don't know the answer, just start thinking through, well, I know it's not this one, right? So using the elimination method to get you there. Come up with the best answer versus the right answer. So not that we're trying to trick you or anybody's trying to trick you, but a lot of times I go back and reread the question and you think about, okay, what are they really trying to get from here, from this question? So really read through the question and understand, what type of answer they're looking for. Use the manual, use the knowledge check. There could be some others out there. Some of this could be even on your own kind of research and just understanding, even if you're going through the manual and different pieces, just to get some basics. There's different tip sheets out there, even from like CMS has done good on the MedLearn site and coming together with different 2-3 pager kind of high level items and understanding, what is covered in transplants, how do I get reimbursed for certain, what are my preventative service coverage requirements? Those different pieces are also provided out there to you as well. I think I got a duplicate slide. There we go. Test taking strategies, definitely be well rested. Like I said, control your breathing. Take a breath. Some anxiety is okay. Don't freak out about it. Have some meals, snacks, definitely hydrate. And the more you prepare, the less anxiety you're going to have going into this piece of it. So you have the tools, you've had this webinar, get the guide, have all of those pieces. I'm telling you, if you read through the guide as well as look back at these different highlights, it's going to get you much better and closer to being successful and not being as nervous to take the test. So certainly if you have any questions, we can open it up now, but also if you think later, just want to reach out, let us know if you took the test, how it went at a personal level. You can contact us. So you have a contact here for the education chair, myself, as well as Marcy, who's our professional certification chair too. So I'll open it up to any questions. If they're very specific coding questions, I will tell you I have to come back to you on those particular pieces, but certainly happy to do so. I don't know if anyone had questions, we'll open it up.
Okay, Caroline, we have a question that just came in. Is there a practice exam?
I'm going to open it up to Marcy. Marcy, there is a practice exam.
What I would suggest is in the manuals, there's the knowledge checks. A lot of people, and I actually talked to a gal yesterday, is printing those off and using those as a practice exam, because the wording is very similar. You have to be careful of the keywords, like what is not part of this rule, or what's the exception, things like that. So those are really good things to just make a bunch of copies and just practice with those, because that's the closest you're going to get to what it looks like on the exam.
Okay, thank you.
I know another good study tip sometimes for me, because I have been out of school for a really long time, is flashcards worked really well for me, because you can, be a passenger in the car. You can, do it if you're, on the treadmill, things like that. So you're constantly studying, and it's a different way than just reading through the manual. And then sometimes reading the answer, kind of Jeopardy style. Here's the answer. What's the question? Is another good way to practice or study.
And certainly, if you have other folks in your organization, or you've made friends through AHAM, like I have, if you have people of similar interests that are looking forward to taking this exam together, even a small study group, if that's available to you.
Absolutely.
Well, I hope this, I don't think we have any other questions. I hope this was helpful. If you have anything that comes out, you think about it afterwards, certainly you have our contact information. You can reach out to me to ask me those. And then also, we're always looking for feedback. So if there's anything there that you expected to be seen, or you have suggestions as we're looking at the exam going into 24, be happy and would really appreciate your feedback on that as well.
Okay, thank you. On behalf of AHAM, we'd like to thank everyone for joining us today, and send a big thank you also to Caroline for an excellent presentation. I'd now like to direct your attention to the survey that I have just brought up on your screen. If everyone could take a moment to fill out this brief survey, AHAM does appreciate your feedback. This concludes today's session. Have a great rest of your day.